Started. I trust everyone can hear me. And I always wonder about that question because if people can't hear, they just wouldn't respond. But thank you all so much for coming out this afternoon. In Los Angeles, it's always a challenge to get people together because of three numbers, 405. And it's made the traffic very challenging here. So whenever I see people filling seats in the afternoon on a school day, I'm always pleased, and I know the topic must be of some interest to you. I'm Gary Small. I'm director of the UCLA Longevity Center, and this conference or this community meeting will focus on a very challenging topic. I mean, something that has affected many people in their lives. I know in my clinical practice, it's a huge issue. And if you think about it, what's the most important day of your life when you're an adolescent? In this country, except in a farming land, when you're 16 and you get your driver's license. It's a tremendous symbol of independence, rite of passage, and so it has a tremendous emotional charge to the average individual. So when we get older and we have cognitive challenges in particular, but also motor challenges and other issues that make it more difficult to drive, then we get to the point that we're going to be focusing on this afternoon, is how do we deal with older people and when they shouldn't be driving. It brings up issues of autonomy, and one of the biggest struggles we see with our patients, people want to remain autonomous, and we want to maintain that sense for them. But there's also public safety, personal safety. So I'm so grateful to Linda Ercole, our Director of Geriatric Psychology in the Geriatric Division, who has organized this panel this afternoon. And I'll have her take over the microphones in just a moment. I also, before we get there, I wanted to just say a few things about the UCLA Longevity Center. Our mission is about living better longer. It's not just about living longer, but we want quality of life as we age. So we have many different programs. Please visit our website, longevity.ucla.edu, and you can learn about senior scholars, where you can sit in on undergraduate classes. We have memory training course that sometimes even though I help develop it, sometimes I feel like I need to take it, especially when I get very busy. And those classes are here in Southern California. We've licensed them all over the country, and many other wonderful programs. And also I want to thank the panel today and the speakers for putting together some of their PowerPoint materials. So there are handouts for those who attended. And I also want to thank our cinematographer, because those of us who did not want to dare the 405 freeway and the traffic out there, we're going to have a video of this conference, and we'll post it on our website for others to learn about the important information today. So thank you again for joining us. And Linda, I'm going to turn it over to you. Maybe I'll take this down.
Thanks, Dr. Small. That was a very perfect introduction for how difficult and important that this topic is. And I want to say, first of all, that I was inspired to think more deeply on this topic by patients and by their family members, and seeing the difficulties that people encounter in dealing with this very delicate topic, and all of the questions that come up that we could say our mothers and fathers never prepare us for is, how long should I drive? When am I not safe? And how do I talk to someone who doesn't realize that they're unsafe? And so we have a great panel of speakers today that are going to talk about different aspects of this topic. And these speakers have different levels of and different types of knowledge, from professors at the UC and VA system to the Alzheimer's Association and from the DMV. So I'm going to introduce our first speaker. This is the esteemed Dr. Jaime Fitton, who is a professor at the Greater Los Angeles Veterans Administration System. He is at the Sepulveda campus. Now, Dr. Fitton has a long tenure as a teacher, as a physician, and as a researcher. And he has been involved in all types of research, including dementia and aging. And a very seminal set of studies that he did was on driving and dementia. And this was some pioneering research that he did. So I'm happy and pleased to introduce Dr. Fitton, who is going to talk today about older age, health, and driving.
Good afternoon. Thank you, Linda, for that very nice introduction. What I would like to cover today in the time that we have, that I have allotted to discuss this topic is I wanted to try to see if we could get to the base, what is the real issue here that we're dealing with when we talk about this very general topic of older persons and driving. So here it is. So let's get started and see if we can identify the nature of the beast, if you like. First, let's look at what is happening in California in terms of the demographics of the aging population in California. These statistics that I have do reflect California statistics, but they are essentially virtually identical almost everywhere else. And if you look at this graph, where we look at on the left, you see the population in millions, and then you have the years up to 2030. So it's a projection from the Department of Motor Vehicles. You see that a very clear pattern that there's an acceleration in the growth of older persons, particularly in the growth of the oldest old. You can see in pink that even though there's a lot fewer people that make it past 85, the growth is remarkable. If we look at the year 2000 and we look at year 2030, it really basically doubles the population of 85 plus. And of course, the younger groups, the 75 to 84 and the youngest of the senior citizen class also are going to greatly increase in numbers. And I think we just shouldn't stop to think of it as just numbers of older people out there, but what older people will be doing and what the changes and the trends have been. If we think about a generation or two past, older people finished work, retired, and kind of just stayed home and did barbecue or a few things, and they weren't very active. That's not the case with the current generation and probably the next generation coming up. People are very active. They like to go on vacations, they like to drive, they like to be doing things because they're enjoying a greater degree of health than was possible a generation or two generations ago particularly. So what we're going to be seeing is a very large, much larger demographic of older persons, and these older persons are going to be a lot more active and probably going to want to be out on the road going from one place to another just like the rest of us do. Let's see. Yes. Now, excuse me one second. Let's look at, today we're talking about safety, and when you talk about safety, we think about crashes and we think about injuries that may happen to everybody, but we're going to focus on older people. And here, there's a number of ways of looking at the data that Department of Motor Vehicles come up with and so forth. And they all have something similar. So in other words, we could look at a number of crashes, serious crashes, injury crashes, or fatality crashes based on per mile driven statistic, or we can look at it as number of crashes per 1,000 drivers and so forth. They actually all have this same pattern that I'm showing you here, and this is a relative injury collision rate by age, so that if we take and we average collisions for all age groups. And here we're going to get a number, and that number is indicated in yellow. And then we look at segments of the population by age and compare them to those overall statistics. And so what we all know is that youngsters, teenagers in particular, particularly teenage boys, are the ones that are most involved, certainly 2 or 3 times the amount of fatal or injury crashes. And that's probably attributable to inexperience and a little bit too much testosterone and peer pressure and so forth, so these kinds of issues. However, we do notice that as these youngsters age and get into adulthood and reach middle age, that they get a lot better. And so if we look at the pattern here, actually the best results in terms of injury collision rates is in the people in their 60s. They do the best. And why is that? Well, certainly experience is one, certainly testosterone levels having gone down, as we're all familiar with, and so forth. And this leads to just an overall better profile in terms of injury and accidents. However, we do notice that as we get beyond that and we start really getting up in years, the rate of injury collisions increases. And if you look at some of the other statistics, where that's coming from is not so much that they're having this great rash of accidents that are just bigger than ever before, but on the other hand, that they're getting more injured and are having more safety problems than younger people because of the aging process. And I'd like to visit that aspect with you now. You'll notice that, of course, when you reach 85, your chances of being in an injury accident are greater because you are more vulnerable. There are a couple of issues here that have to do with our increase in vulnerability. And one of them is the fact of the aging process itself, which may be relatively free of major illness, but we still get old, our hair still turns gray, we still get cataracts and so forth. This is part of the aging process. And part of that aging process is that we inexorably march towards this concept of becoming fragile, frail. And what does that mean? Well, it's been greatly debated in geriatric medicine circles and so forth, but I think the two things that we can take away from it is that we lose resilience with age, even if we stay relatively healthy. We don't respond the same way to challenge, whether it's internal challenges or external challenges. And second of all, we become more vulnerable to adverse results, events. That means because we become frail, we're more likely to wind up in the hospital, in an institution, having to be cared for by someone else and so forth because of frailty. Not necessarily because there's a particular illness, though often illness does compound this process of getting older. Because illnesses, particularly of the neurodegenerative and cardiovascular types, are certainly much more prevalent as we get older than when we're younger. So we have on the one hand, we have the frailty issue, and on the other hand, we have the diseases that we're more vulnerable to as we age. And particularly for driving, there's probably no other that's more impactful than losing brain health. In other words, acquiring a dementia. Most commonly it's Alzheimer's, but it can be others, or it can be a mixture of a couple of pathologies. And you can see here, just by this demographic, that if we look at the percent of the aged population with the diagnosis of dementia, that it is relatively small in the mid-60s and, again, follows an exponential increase as we get older, such that by the time we're 90 years old, we're talking about a 40% chance of having dementia. And you know, there's some variation, slight variation in these numbers because they come from different studies and so forth. But this is a sort of a ballpark. And by the time we're close to 95 or above, our chances are 1 in 2 that we will have a dementia. At this point, most likely that's going to be Alzheimer's disease, possibly mixed with some vascular disease. So we're going to become more frail, and we may have, upon that frailty, have to deal with a variety of diseases. The most important for driving, in my estimation, is dementia, because you need, above all, your brain to be functioning right, to be able to make the perceptions and the decisions that you have to make in a relatively short and compressed time. The other thing is that driving is never exactly the same, except for the basic. You get in the car, you turn your key on, you put it in drive, and you go. And those kinds of things are overlearned material, and they don't really rely on our gray matter, our cortex, very much. All that is handled by subcortical systems where we don't have to be aware. So I'm sure you've all had the experience of, say, driving to the market. You get in your car, you go, you're thinking about a lot of things, and all of a sudden you're in the parking lot, and you may stop to think, how did I get here? I don't really remember any particular detail of getting here. And that's so that we don't need to be fully aware of some aspects of driving, but other aspects of driving. For example, you're buzzing along in the 405, and something changes in the landscape, the motor landscape up ahead. There's lights, or there's a police, and all of a sudden, what you were listening to on the radio, what you were thinking about, gone. You are now highly focused, and you are processing, and you are trying to assess the problem and what you're going to do about it. So fortunately, we do have this capacity of going from automatic to full consciousness and awareness of what we're going to be doing in the next few moments. That, of course, that particular aspect requires brain health. If we have cognitive impairments, that's going, and depending on the type of cognitive impairment, it's going to affect it more or less, but say in the case of Alzheimer's disease, as you will see through some videos this afternoon, it makes a big difference in what you can do when you have Alzheimer's disease, particularly in a situation where it's novel, you don't know what's coming, you have to assess it, you have to act quickly, make the right choice, and stay safe. Now, we've all read the newspapers, and we all see that older persons tend to get bad press about driving. And I personally don't think, having done a number of studies in this area, I personally don't think that if you're an older person and you're healthy, that you're going to have much of a problem. We've done hundreds of subjects, driving them under a special course and so forth, and we find that the healthy older persons do fine. They're about the same as the younger individuals. So in terms of their decision making, in terms of them handling traffic situations and so forth. So that we really need to be more concerned with the impaired individuals, those that have impairments of various sorts that may impact driving. Certainly brain impairment is way up there. And so in this graphic that you have here, you can see that in California, there's approximately 3 million older drivers above the age of 65. Of those, an unknown but approximate, represented by this white circle, approximately a substantial percentage of those individuals are impaired. They have various impairments that are significant to driving. And what is reported is not how are those impaired individuals doing versus those that are not impaired, because that's very difficult to get at. In crashes and so forth, can you getting access to the person and testing them and so forth, it becomes a very difficult to do project. And to my knowledge, I don't think that there's any really significant study that has looked at this dimension. So we really don't know exactly of the crashes how many of those crashes are caused by impaired individuals versus healthy older individuals. However, this is an estimate, and in terms of impairment, again, we're talking about for older individuals, impairments such as dementia, poor vision, musculoskeletal difficulties such as, you know, we get arthritis and we can't turn our head one way or the other and so forth, or we have a hard time working with our hands, pushing buttons or doing things. It's not as easy as it used to be. So those kinds of problems, and of course, older persons take a lot of medications, and some of those can have a very significant impact. Pain medication, so forth, that will alter the level of sharpness that you can think with. Now, you'll notice that I have dementia in yellow, and that's because of those three, it's the one that we can do least about at this point. The one that we can, say, reverse or really improve the symptoms. And I can give you just in passing a comment on that. We've looked at the patients with Alzheimer's disease that we've driven, and we've looked at some that are on medications and some that are not on medications, and they're indistinguishable one from another in terms of the quality of their drive. So it doesn't look like these medications are, in most individuals, sufficiently powerful to make a change. So we really can't alter to a very significant extent the cognitive functioning regards to driving in persons with dementia. The others can have some possible remediation. If you have cataracts, you can have surgery. If you don't see well at night, you drive during the day, and so forth. The compensations are possible for all of the others. So the one the really hardcore one we have to deal with is the dementia. And there are various types of dementia, the most common of which is Alzheimer's disease. And what I'd like to do now is to show you, based from our studies, and the quality of the video is not as great as I'd like it to be, but that's because these tapes are from an older study, and there was VHS at that time, not the fine stuff we get today, but it's still very obvious. You'll see what happens. So I'm going to start out by showing you how a woman, don't start again, how a woman that is 90 years old drives. This is a healthy woman. She did fly to New York to visit her relatives, came back, walked her dog every evening, went to the groceries, lived by herself, and was very autonomous, very vigorous, was in a bridge club and so forth. So this was an older lady, 90 years old, that was in good health. And so I'll show you that first, and then in comparison, I will show you a patient with, could be her son, with Alzheimer's disease in the early stages. So the number of men, we were able to determine that this was a early stage Alzheimer's dementia. He was still fairly autonomous and so forth. So we'll do that. In the time allotted, I have a lot more, but I couldn't show you all of that because of time limitation. So I just want to show you the contrast and how age does not necessarily mean that you can't drive well, provided you're healthy. So what you'll see, we're going to go through essentially two main things. In previous studies before this, we had looked at what are the situations that older people or people with dementia have the most difficulty in dealing with. And we found out through the studies that they had the most difficulty with intersections that they hadn't seen before. So this you'll see the drivers approach one intersection where there's a set of signs, and that leaves only one alternative. That is the first one, that the person has to turn right. And the second intersection, you have to stop and make a left turn. How well does an Alzheimer negotiate that versus a healthy older person? Let's have the videos. By the way, fasten your seatbelts. This is just to make sure you don't, you can play, do play. Anybody for salsa? Hit play. Hit play. That's the one you need. That's it. Okay, so this is from a third study that we did on this issue back in the 90s, and these tapes come from that. So again, my apologies for the VHS quality in the tape. This is our healthy control, 90 years old. Would you have the volume on that? Yes. This is done on the grounds of the Sepulveda VA, which is sort of like a community drive. And we're approaching this intersection. There's some bumps on the road, and see how she handles that.
You didn't slow down. You'd be surprised at people that don't slow down.
Now we're approaching the intersection, and remember, there are 3 signs there that where the only possibility is to make a right turn. We provide no instructions so that it's an autonomous choice.
I can go that way.
She negotiates the turn safely. Here it was another event that we staged, which was a construction zone, and we saw how people dealt with that, and most everybody, with some exceptions, did okay with this. Now we come upon the second intersection, which is a left turn. Here it is. You can see the sign, no right turn. There's a do not enter straight ahead, and this is a flashing red light on the left. You have to make a stop, and
No, I have to go that way. That's the only way I can go, isn't it? Yes.
okay, now we're going to see what a much, much younger Alzheimer patient in the early stages of the disease, how he handles these novel situations. The lens is a little different, so it looks like he's more to the left, but he's still on the correct side of the road. He manages the turn very well. Here's the intersection. Listen to what he says. Now, this is a double-sided control
I'm
panel.
gonna put in the brake.
Oh,
You have to look at the sign, it says do not enter.
oh, sure.
That one says do not enter.
Uh-huh.
So you can turn right here.
I'm
What do we
sorry.
do about that? We can't back up with the wheel.
Oh, well, get out, boy, come back.
We had a fifth wheel, so he couldn't back up, but we had to wave the traffic around.
So I'll turn the brake.
That was unscripted, but he handled it okay. Remember, this is a dual control car. That young man was heavily insured. Here's that other intersection.
Keep straight.
Just look at the signs, Mr. Alderson. What do the signs tell you to do?
Do not enter. No, that's
So he
right.
can read.
So which way do you have to go?
I guess I'll go back to the right.
Still a left?
Left. Oh,
You turn your signal on. Your signal on. Now you need to check around and make sure there's nobody. Okay.
Okay, now this is a real hairy ride, so, but we don't have time, so I'm afraid I can't show you that. You want to, are you buckled down good? All right. Some of these drives are amazing, I'm telling you.
Slow down.
The monitor's having to apply a little brake there.
Follow the road. When you see those bumps, you need to slow down.
You notice that they can stay on the right side of the road.
Okay, push foot on the brake, Mr. Rasmus. Push foot on the brake, push foot on the brake, push foot on the brake, push your foot on, there you, no, push your
He's
foot
got
on
his
the
foot
brake.
on the
Mr.
accelerator,
Rasmus, push your foot on the brake. Push
and
down
he
on the
can't
brake.
take it off. He's engaged. He can't
Which way can you go? I
decouple
want you to
himself.
look at all the signs, and you tell me which way is right.
This is what happened in that Santa
What does that
Monica
sign say?
accident.
Is this enter to you? Okay, I want you to turn right for me. Turn right. Turn. Come on, Mr. Johnson, you gotta turn the wheel. There you go. Straighten around. Okay. Slow down.
You notice he's standing way back now.
Mr. Johnson, you really have to turn the wheel. Turn, keep turning. Okay. Push foot on the gas. Okay, straighten the wheel now. Straighten it out some more. Okay. Okay, push foot on the gas, let's go. No, don't stop, don't signal. We're gonna go straight. We're gonna go straight, Mr. Baskin. No, take your foot off the brake. No, take your foot off the brake. Take your foot off the brake, put it on the gas. Take your foot off the brake, put it on the gas.
She may regret that.
No. What does it say straight ahead? Okay, you need to go to the left. Go to the left.
Okay, it's more advanced disease, and I think it's very clear. There's other types of dementias that we also looked at, and there are some little differences, but they still have a lot of difficulty, and I wouldn't want to be a passenger in cars like that. Also, for those spouses that function as co-pilot, you can understand that sometimes they have, it's a hairy experience, you know, that they're doing things that you can't really control. So I hope that I just wanted to illustrate, and I think you'll have another video that's similar to this, that illustrate the difficulty that patients with Alzheimer's may have, particularly under certain circumstances like novel situations, novel left turns where you really have to bring your full awareness and decision-making powers and integrative powers in a rather short amount of time together so that you can proceed with the right choices. And I think that these kind of show how persons with dementia, and particularly Alzheimer's disease, can't do that. And if they can do a little bit of it, they can't do it reliably. So I think that here's a little bit of evidence that suggests that maybe those accidents and so forth maybe involve more people with impairments than those that are healthy. So in summary, I hope we've established that a percentage of older drivers are impaired. We need to improve detection. And that's been a problem. You'll be hearing some of that in the subsequent talks. We are currently finishing a study that will allow us to provide physicians with a way of quickly testing a person. Even the nurse can do it, and being able to say, this is a validated test and so forth. You really shouldn't be driving, because many times physicians don't really know. They're not driving experts, and they really don't know what they should advise the patient or what they should do with regards to reporting the patient. California law states that physicians, if there's a diagnosis of dementia, they have to report. But sometimes we see people that don't have the diagnosis of dementia, because in primary care that tends to occur, the diagnosis tends to occur considerably later. Physicians are busy taking care of a bunch of other things. So that happens a little later, and the person may be already driving impaired before the diagnosis is established. So we need to improve detection methodologies at various levels. And then I think that certainly clarify the roles for the DMV, the families, family physicians, community organizations, and the private sector, and improve their integration so that we may have a better screening and better interventional approaches. And you'll hear more about that in a moment. We also need to try to improve transportation alternatives for older adults, and that's a problem. You know, we've been through a big recession. There's no money. There's not these things these interventions that could be available, you know, are not. And we so rely on the automobile that you can imagine how difficult it is if you live out in a more sparse area. You may not be able to get into town if you don't have a car. So it becomes, transportation alternatives are important. And then finally, hopefully we can affect policy changes to improve safety. And I have one particular in mind just as an example. Recently read an article whereby by 2035, close to 50% of the cars are expected to be self-driving cars. And if that pans out, and we're certainly moving in that direction, and there's a lot of interest because it's believed that that will greatly reduce accidents. But if that's the case, they're going to be probably more expensive. And so a policy decision would be to provide subsidies for older persons to be able to acquire such vehicles so that they can move around safely. And so this is the kind of thing I'm thinking about, policy changes to improve safety. With that, I conclude, and I suppose we'll have a little discussion session afterwards. Yeah, thank you.
I thought it was Susan Howland next, but it's actually me. So that was a great talk, Dr. Fitton, and I think it was very compelling, both the issues that you laid out with driving with dementia, and then the videos, which I'm still a little, the blood's still coming back into my knuckles after those eyes. So this is a perfect segue for this talk, which is about what happens when someone has dementia, you're a caregiver, you see troubling driving skills, and your loved one doesn't realize that they're an unsafe driver. What does one do? And like I said before, this was inspired by working with families, both the patients and the caregivers, and to find that there is not a lot of information out there on how to broach this topic, and people find themselves in quite a bind when the situation arises. So let's pick up where Dr. Fitton left off. Is why is it so difficult to turn over the keys? Because it is tremendously hard. And the transition is difficult for a lot of reasons. One is that some individuals, because they have dementia, lack awareness that they're unsafe. This is often part of the dementing illness. So it's not that somebody is being stubborn or they're doing this on purpose, but that they actually, because of the disease process, lack the ability to recognize that they are no longer a safe driver and they shouldn't be driving. The other is, again, that Dr. Fitton and Dr. Small pointed out in the very beginning, what is one of the most important things that we do at a young age, or one of our rites of passage and our gateway to independence and autonomy is driving a car. And so turning in the keys means a loss of autonomy, a loss of independence, and so much is at stake. The things that we often take for granted, like getting to the store, getting to doctor's appointments, meeting a friend for lunch, and going out driving to go take a walk in the hills or going to the gym. And also very much one's sense of dignity is at stake. And so there is a lot to lose when one turns in the keys. The other is, a consequence of this is that, and research studies show that retired drivers might become depressed and withdrawn. So because of this loss. So there is a lot of resistance and reasons that one wants to keep driving. And often, though, the burden of helping a loved one transition to, I call a retired driver, and filling in the transportation needs falls on the family. And then again, this transition is not only difficult for the actual patient that has dementia, but also for the family too. So families are usually one of the first people to notice that somebody is not driving well. All right, so for example, they go for a ride, or let's say it's their mother drives, and they'll be in for an experience like one of the second or third video perhaps that you saw today. But families might be hesitant to intervene, and there's a few reasons. One is they have a lot more burden placed on them when somebody stops driving. So how does that person get to their appointments? How does that person continue to lead a normal life? So often the time, the transportation, and the monetary burden of arranging for transportation falls on the family. So it's not something that is an easy transition for the family member either. Families also fear that they will damage the relationship with their loved one if they broach the topic of time to stop driving, or worse yet, if they actually do something drastic like take away the keys. And finally, many family members just don't know how to go about this. And this is something that I've seen in our caregiver support groups. It's a really tough problem, and there is not much information out there as to how to go about this. And furthermore, there is no general uniform situation. Everybody is different. And some people will actually say, I don't feel safe anymore, I'm going to stop driving, and other people don't. So everyone's situation is different. There's really no cookbook for how to transition. But there are some steps to driver cessation. And the first one we've actually already been exposed to, and that's Dr. Fitton's education about what happens with aging, and particularly in dementia. Because the more somebody knows about what happens in dementia and how people behave and how people think, the better they can be aware or ready for the warning signs, which is number 2. And I'm going to show in a minute a slide about some of the warning signs of unsafe driving. One also needs to get driving alternatives in place, preferably before one stops driving, right? And we're going to talk in a moment about how to broach the topic of cutting back, limiting, or stopping driving with a loved one. And in this case, in this process, it's very collaborative. If at all possible, you want to involve your loved one as much as possible, involve the help of others, and in any event, try to maintain the dignity of the person during this process. And the last one, which I'm not going to get into much today, is sometimes when safety is at a premium, family members sometimes have to take more drastic steps and limit access to driving without the loved one's approval. Okay. So we talked about already education about dementia, and I'm just going to move past the slide because I think you've already gotten some vital information on that. Here are some of the warning signs of unsafe driving. The red dots, these are little stop signs. That mean these are the signs that one should really stop immediately. And so you can find other warning signs of unsafe driving on the internet, on the Alzheimer's Association website. So if you actually want to see this or other warning signs, you can Google it, for example. But let's talk about a few of them, some that might ring a bell for you. Has anyone noticed that somebody might have less confidence in driving? Has anyone ever seen that in a loved one? I know I have. Yeah, and you know what? My feeling is go with that person. If that person doesn't feel like they're safe anymore, if they don't want to drive anymore, go with their instinct. Sadly, I've seen families try to push patients into driving, which raises the issue that it's not always the patient who keeps driving on their own accord, but they feel pressured to do so. So that's one. Let's take a look at another. How about how is the person driving? So again, Dr. Fitton's video was really telltale. Do people stay in the lanes? Do they stop? How do they navigate turns? How do they read the road signs? So these are other observations that one can make. What about accidents? Has someone had near misses? Or have you noticed that they have new dings and dents on their car? And does your loved one, what do they say about those dings and dents? So what about accidents? And what about things like needing a co-pilot to drive? So those last two videos are great examples of somebody needing a co-pilot to drive, including one that has their own brake. And it didn't work very well either, did it? Or confusing the gas and the brake. We saw concrete examples of that. And finally, stopping in traffic for no apparent reason. And I don't know how many of you have been on the freeway, on the great notorious 405, or going down Wilshire Boulevard, and maybe you've had that happen to you. And those are immediate stop driving warning signs. This is sort of a litmus test. And this is kind of the be honest with yourself. Would you let your child ride alone in the car with your loved one who's driving? Now, I did not make this up, but this is sort of what it all comes down to. If you're not sure, many people it's suggested that they ask themselves this question. And the answer to that question can give you insight into your true feelings about how comfortable you feel about someone's driving. So what are the steps? So we talked about education about driving. We talked about learning the warning signs of unsafe driving. Another thing that is suggested for a loved one to do is to actually observe driving. So if you live near your parent, or of course it could be a partner or a spouse, go on ride-alongs and do these in different areas and in different situations. And ask yourself or make notes of how does your loved one drive in these situations. For example, what's the quality of their driving? Pretend you are a DMV driving instructor taking someone on their licensing test. How do they behave around pedestrians and cyclists? Do they check blind spots? Do they use their signals? And again, think about that video that you just saw. That's a very good thing to do. And try to make notes of the frequencies of problems when driving and the situations in which they occur. So you might see something close to home, or you might see a problem on the freeway but not close to home. So this one is important. Have conversations about driving. Now this is the most difficult thing for people to do. So a suggestion here is think about this conversation about driving as a process, all right? And actually, it's better to have these conversations way ahead of time. So if you yourself are aging, if you have a loved one who's aging, these are perfectly acceptable things to talk about. This is not taboo. Thinking about these kinds of things ahead of time, just like we think about advance directives or a will, it's really important because it can save a lot of heartache when the time comes that one really does have to stop driving. So think about this as a process. Start with short conversations. Now, in the case of somebody who really does need to stop driving but is reluctant to do so, start with short conversations. You might ask someone, how did it go on your way to the store today? How did it go on the way to, the bowling alley, the beauty shop? And let the person talk. Find out about, did they have any problems, or how did they feel about their trip? Did they have any difficulties? Then after you sort of break the ice and have these short conversations, again, not getting into any big argument or anything like that, just short ones, then you can start to have longer, more serious conversations, particularly when you've seen right along some problems. So an example might be, Mom, there'll come a time when you'll not be able to drive safely. Let's talk about what to do to be prepared for that time. And then at this point, this is recommended by some insurance companies, like the Hartford Insurance Company, is to even have a contract with your loved one to stop driving. So it's like, when the time comes, if you're not driving safely and I notice it, will you allow me or trust me or some other designated person to be the one to talk to you and help you transition and to stop driving? So this may or may not work, but again, it's a great tool to try. And finally, please share your concerns and have your friends share their concerns. So I'm worried about how you manage that turn, or there was a near miss at the intersection. That really troubles me. And I think having their friends share concerns is a big issue, and that's because we actually hear of cases where people say, my mom is not a safe driver, my dad's not a safe driver, and I've told him. He says it's not true, and then he called up his friends, and all of his friends said, oh, there's nothing wrong with your driving. And so this does not help get the message across. And it would be important then that everyone shares their concerns. You can also have professionals involved. Now, doctors can have a very powerful role here because they are trusted, they see the patient a lot, and they might be able to do, and they usually do, assessments of people's cognition that gives insight into should this person be driving or not. And a great way is to have your doctor, the patient's doctor, talk to that person. And that kind of leaves you out of it and leaves you not being the bad guy, because often the loved one that has that conversation can be the bad guy. And some doctors actually write a prescription, do not drive. And we've heard that I personally heard that this can be very effective for some patients. So don't hesitate to involve the patient's doctor. And one thing is important is if you don't tell the doctor is not going to know. So give your doctor or your patient's doctor a chance to help. And again, this is a collaborative approach. So you and your loved one can make choices about what kinds of transportation alternatives there are. Let's talk about your schedule. On Mondays you go to lunch, on Wednesdays you go to the gym. Let's talk about how we can get you there and keep you doing all the things that you like to do, even though you're not the one to drive yourself there. Okay, that's a collaboration. And have your loved one help come up with some ideas. Again, depending on their cognition, they'll have less or more ideas, okay? But the idea is to partner as much as possible in this process. And then here's an example of partnering with a driving agreement where you actually entrust someone to broach this topic with you. So key word is when it's not reasonable for me to drive, I desire so-and-so to tell me that I can no longer drive. And this is from the Hartford Insurance Company. This is what a form that they have, that they put out to the public. And I know we're running out of time, so think about a good transportation plan, and you have to get creative. And this really depends on funds. It also depends on how the cognitive resources of the patient. So some patients, you would not want them taking the big blue bus by themselves, right? So, but there are plenty of alternatives out there, whether you have kind of shuttles with families and friends. Sometimes community organizations have transportation. Sometimes senior centers have vans. There is access and mass transit. And now they have many options for hire. You've seen the Lyft cars? Has anyone seen Lyft? Or kind of, they're like different types of taxi services available, and they're pretty reasonably priced. But again, the actual transportation plan is going to depend on, can this person go alone somewhere? And if not, then you have to adjust your options. There are lots of resources out there. So we talked about the doctor and websites, the Alzheimer's Association, which we're going to have Susan Howland here to talk about that in a second, the DMV, and there are also driver safety courses that can educate older drivers, and there are tests. And there are different kinds of tests out there. There are road tests, there are simulator tests, and there are even some online self-tests that someone can take. Now, I'm not sure of the validity of all these tests and how well they, especially the online test, how well they actually can identify someone who's not safe, but I think the point is that it's some information that's coming in. And if you can get somebody to take a self-test, then that is better than somebody not taking a test at all and thinking they're just fine. Finally, sometimes one has to impose driving cessation, meaning literally you might have to block access to the car, take away the keys. This is something that you don't want to do. It's not pleasant for anyone. It does happen. Sometimes it has to happen, especially when there is a lot of risk. Because what you don't want is, you don't want to let an accident happen. And I think the Santa Monica Farmers Market is a prime example. And my feeling about that is, I remember the horrible things that people said about that man, that he was laughing and purposely did that. And being in this business, we knew that that was not true, that he was somebody with dementia who mistook the gas for the brake. But what a way to go out of this world with that on your back and on your conscience. Not to mention that 10 people lost their lives. So we actually here at UCLA are trying to develop a project to test a driver cessation program in the sense or in the context of a caregiver support group, where we have caregivers who need help with this issue. And there was a small study based on an insurance brochure called At the Crossroads that taught how to have conversations with parents. But we're proposing something much more extensive, where we actually not only learn to have conversations, but talk about other methods for driver cessation, and to actually test at the end if people do limit or stop their driving. So this is something that we're working on to get funding for at this time, and we hope at some point that we can test this out and develop it further. So I just want to thank you for your attention, and now introduce Susan Howland. So Susan is here from the Alzheimer's Association. She has a master's degree, a master's of science in gerontology, with over 20 years of experience with community organizations surrounding healthcare issues for older adults. Currently, she is the director of education at the Alzheimer's Association, which is in the Southern California chapter. And she is responsible for all educational programs and diversity efforts that include tailoring services to the cultural norms of ethnic communities. In this capacity, she oversees a number of nationally recognized programs serving dementia-affected older adults and their caregivers throughout LA County. So Susan, welcome.
Thank you very much. First of all, I hate bios. They just always sound so, you're full of yourself. So my name is Susan, and I work at the Alzheimer's Association and basically interact with family members and individuals with dementia on a daily basis. And dementia and driving is a huge topic. It's really a large challenge for both the individual as well as the family. And we hear many, many caregivers say to us that they know their loved one is driving in a manner that is unsafe, but they don't know how to approach this topic. And it's for fear of upsetting the individual, for fear of kind of disrupting or contributing to some family discord. Well, my son thinks he's okay, but my daughter knows there's something up. As well as maybe not being ready to step forward to figure out some of the solutions. And what we're seeing also is a lot of people don't think that dementia impacts cognition more than just memory. Well, he's still driving. Yes, he gets the dinks and dings. He gets honked at. He doesn't make those, he doesn't slow down for those bumps, but he can remember how to get home, so he's still okay. The second hat I come to is as a family member. We struggled with this with my grandmother. And so I can also kind of talk to caregivers about that personal experience as well and how difficult it is. And we do know that most families start to notice problems with cognition through the driving. And it's everything from he went to the doctor's where he's been going for the last 30 years, it's 5 miles away and it took him 4 hours to get there, to he got a new car and he doesn't know how to operate it because it's a different car, it's a different system. So frequently these are some of the kind of first indicators for families that something is going on. So again, a lot of my slides, I think the points have already been clearly and articulately expressed, so I'll just add pieces. But clearly, individuals who have Alzheimer's or progressive dementia, the symptoms will get worse over time. So we know everyone with Alzheimer's will eventually not be able to drive. But at any given time, especially for those who are mild early on in the disease process, potentially they might be able to in a limited capacity. Also, individuals who do have dementia frequently kind of make up excuses or don't acknowledge that they are having some difficulties. They don't have the insight into that difficulties that they're experiencing. Yeah, I had an accident today, but no one was hurt. It's okay. And also the tendency to minimize the complexity of driving, everything that you've already heard, as well as their own abilities. And this was a quote that I think sums up rather nicely. So it's an individual who was recently diagnosed with dementia, and he said, my sons and daughters had a meeting without me and decided they want me to stop driving, but they're making a big deal out of nothing. I'm very comfortable on the road. I've driven longer than they've been alive. So again, it brings up issues where families also often have these conversations without that person and sort of that tension that starts to create between the family members and the individual. Again, signs of unsafe driving. Again, there are lots of lists and check boxes that are available for you to look at. I do have an additional video of a woman who's in early stage, and she is going to have her DMV, or an on-road driving evaluation. And again, this is a woman who functions really well in her day-to-day life, but you can start to notice some of these unsafe driving behaviors as she's trying to take this test. Okay, so, I can't use a mouse in front of people at all. It looked like it was able to run in the PowerPoint. I think if you, yeah. the long-awaited video.
So what we want to do is we want to back out and go to our left when you feel like it's safe. What is reverse? Three, yes. So we want to use the reverse, which would be what? Which would indicate reverse on there?
One, maybe two is reverse. You're gonna have to tell me.
The R stands for reverse.
Okay. R is reverse and N is in neutral.
Correct. I understand this is a different car for you, so that's why we're warming up in the parking lot.
Now, where am I going?
And we'll follow the link here until I ask you to make a turn. We're going to stay in the right lane here. Make this next right turn coming up. Make sure we don't go into any oncoming traffic here. We want to stay behind. Can I ask you why you're stopping here? Can I ask you why you did it?
Wasn't
It's
there
not
a stop
stopping
sign?
me to ask. No, there was no stop sign there.
It was some reason.
It wasn't for the road that we were traveling on. It was for a different road. Next traffic signal we come to, we'll be making a right turn. State Bank Road. And we'll be making a right turn. This traffic signal. So it's however you can safely do this. We have to go fast if we can.
You told me it's right turn,
A right turn, correct.
and I'm passing.
That's okay. We can get us turned around and we'll go back and then we'll make a left turn.
So many closed off places, I guess. Residents can't go up there. Yeah. Oh, shoot. Now, I'm trying to decide, should I go with then turn around, but I guess I'll do it like this. This is the hardest thing I have to do today.
So clearly, I think it was pretty easy for most of us to spot a couple unsafe driving behaviors and maybe several of your stop sign lists where obviously she needs to stop immediately. Again, starting that conversation sooner than later is always the best, but what we find is it doesn't occur. I will add just a couple more points to the previous presenter, is that it's also trying to have that conversation and position it in a way that's the least kind of defensive. You know, there's a different approach between, oh my God, your car looks horrible, versus I'm having some concerns about your driving. We also encourage taking notes, very specific notes. You know, on Thursday, January 16th at 3:30, you were leaving parking structure 8 and you hit a post. And again, being able to identify those issues. Also making sure you have a plan who you want at that meeting. They've never gotten along with their son, so we're probably not going to invite him. Also, of those individuals at that conversation, who is going to take what role? Who will bring up alternatives? Who will initiate the conversation? And then the last point is to practice ahead of time. Usually human nature, or maybe it's just me, but it's easy to chicken out at the last minute or just decide it's not the right time, because it's never the right time. But if you actually practice, you're more likely to go through with having that conversation. And also being able to practice in advance allows you to kind of role play. Well, what if he says this? What if he says that? What if it goes really horribly? What if it goes really well? So again, you're kind of prepared for some different options. For individuals in the earlier stages, that do have insight, again, you know, we do appeal to that sense of responsibility, you know, your litmus test. The driving contract seems to be very successful, so for some individuals as well. Is there a way to reduce the need to drive? Can the local pharmacy deliver the medications to the house so she doesn't need to drive to the local pharmacy? Can Vons deliver food? So again, it might eliminate that trip to the grocery store. So how can you reduce that need to drive in a very kind of an acceptable manner? And again, enroll in Medical Alert Safe Return, which is our Wanderer registry. About a year and a half ago, I think, or 2 years ago, Sammy Lee, who was the first Korean American to win gold medals in the Olympics for diving, he went to his local pool that he goes to every day, and he was gone for 3 full days. And he was still able to go to each gas station and fill up his tank, but he clearly was unable to find his way home, and he had a bracelet, so he ended up being reunited. And then clearly a driving evaluation. I think one thing that astonishes some families is that they have the conversation, they have the contract, it seems to go well, he or she is not driving, and the issue reemerges. So in the mid-stage, maybe individuals have forgotten that they agreed to not drive. Maybe there are other issues, some other behavioral management symptoms that are arising. Maybe they're starting to wander. Maybe they're starting to think it's okay if they go out in the car and drive. So oftentimes caregivers do have to revisit this conversation about driving later on in the disease process. And I think it really also just underscores the fact that each family is so different and each person is so different. So what does work for one family and one individual one day may not work for them another day or another family. So we do know that disabling the car works better for people in the mid-stage. People in the early stage find that to be punitive, abrupt, extreme. We have people in the early stage of the disease who say, well, if you pull the distributor cap off my car, I'll just call AAA to fix it. So it's not, again, going to work for someone in the earlier stage, but someone in the mid-stage, it might be more successful. Selling or giving away the car, it's going to be cheaper in the long run if we use a taxi every once in a while than to maintain insurance, maintenance, and gas on the car. Some families have success with securing the car. Again, it all depends on that family. In this case, the uncle, he was great. He had like a 1974 lime green Cadillac. I mean, how do you miss that? And he was also a hoarder. So what they ended up doing, which again was successful for this family, is they were able to move that lime green Cadillac into the backyard, secure the gate, padlock. There was no way this car was getting out. And they also took away the keys, but left the car unlocked. So every day after lunch, he would take whatever items he had gathered during the day to hoard, go out to his car and sit in the car. And to him, that was an acceptable solution. He still had his car, he still had all of his hoarded items, yet he didn't have the keys, and it was a safe situation. Another family said to their father, you know what? It's Father's Day. We want to drive you. Because he had moderate stage, he then was told it was Father's Day the next day, and the next day, and the next day. But to this gentleman, that was a very acceptable solution for having his grandchildren or his kids or a neighbor drive him around because it was his special day. So again, it's different ideas. This is where I find caregivers are really creative and successful. Also removing triggers. You know, if the car keys are by the front door, a purse, wallet, that might instinctually trigger that behavior of wanting to go outside and potentially drive. So what we have is the Alzheimer's Association is a couple different resources. Online, we have a Dementia and Driving Resource Center. What I really like about this is that there are 4 videos of families dealing with taking away the keys in 4 very different situations. And they're pretty brief videos as well. They're a little scripted, so it's a little ideal, but again, it gives you good examples of how to approach the subject. Also on that same website, we do have fact sheets about both driving and safety. We do also have the driving contract. We do have access to the Hartford publication, and you can use a navigator system where you put in your zip code, and it will show you if there are any driving evaluation specialists or resources in your neighborhood. Also, we have our helpline. So anytime any family member has a question, even a professional, about how to take away the keys, how to limit driving, how to address this issue, we have someone who can answer those questions. We have care consultants who will work with families one-on-one to kind of address these ideas and brainstorm. And again, these are all at no charge. We have 2 classes. One is Conversations About Dementia, and the other is Savvy Caregiver. Again, typically for family members, but both deal with, at some point, driving and how to address those issues, how to have those conversations. We have a memory club, which is for individuals in early stage, and one session is about driving and encouraging these individuals to write the contract, to identify when their behavior might not be safe and how they want their family to address it. And then we also have support groups for family members, because that is where those creative ideas come up, how to address this behavior. Well, I've tried this, and it hasn't worked. Try this. And then there's several videos. One I looked at recently that's good is Into the Other Lane. And again, it's different families dealing with driving. And it, again, gives you different ideas as to how to address it, how to approach it, and how to maintain kind of the independence of everyone and safety. So I think that's it. Thank you very much.
Great, we have one more speaker, and thank you. That was a great talk and also very informative. Before I introduce our next speaker, the Alzheimer's Association is a terrific resource for people, and it's right there literally at your fingertips to investigate this topic more. Okay, now I would like to introduce our final speaker, and this is Mr. Ismail Anda, and he is a senior driving ombudsman from the Department of Motor Vehicles in Orange, California, and also in the neighboring areas. He is a senior driver ombudsman, and the program was created to assist seniors in driving as long as they can do so safely. And Mr. Anda has been with the DMV for 25 years. He's held several positions there, including a position as a driver safety officer, in which he conducted administrative law proceedings for over 11 years. And it's my pleasure to have someone here from the DMV, because I think so many of our caregivers always think, the DMV, oh, they're gonna get me. They're gonna get my loved one. And so it's really great to have you here and in person to inform people about exactly what you do in these situations.
Thank you. Testing. Can everyone hear me? Testing. Can you hear me?
That's for the video.
So this is for the camera. So just use this for the camera, and then that's for the audience.
I'm gonna have to multitask. Okay. Can everyone hear me now? Yes. Great. Okay. Again, my name is Ismail. The last name is Anda, and I do work with the Department of Motor Vehicles as a senior driver ombudsman. Now, this is interesting in that this is the first presentation where I've come where a lot of the areas that the previous presenters discussed, I usually address to a degree. I was impressed with the presentation from the previous presenters. Excellent information that you provided. We, the Department of Motor Vehicles, in essence, well, let me fall back a little. When I was a driver safety officer, I went through an extensive, rigorous course. It's 1-year training. It's multiple modules. We go through the process. The position itself can take anywhere from 3 to 5 years. It depends on how quick you can learn. But it can take 3 to 5 years before a driver safety officer feels comfortable, because they're conducting administrative law proceedings from DUIs to conducting administrative proceedings for anyone that has a physical and or a mental condition. negligent operators, fraud, commercial disqualifications. Now, the Department of Motor Vehicles, we're not going to be aware of an individual that has a mental condition until we're informed, either by a family member, a physician, or sometimes an officer. For example, if an officer observes possibly reckless maneuvers or an unsafe maneuver as the subject was driving, the driver was driving, then they will refer him to the Department of Motor Vehicles. Now, I'm going to deal more with the Driver Safety Division. We conduct the administrative law proceedings. We deal with all law referrals. We deal with physician referrals. We will deal with family member referrals, friends, neighbors. Neighbors will sometimes notice another neighbor possibly striking their own fence, their walls, or possibly striking parked vehicles, and they will make these referrals to the Department of Motor Vehicles. The Driver Safety Division will receive this referral. We will review the referral. There's someone that's designated to review the document. Once that individual reviews the document, we determine whether or not we will take an immediate action or whether or not we will submit a medical to the customer to have the physician complete the medical. Once we receive the medical, and the medical can be due anywhere from 7 to 21 days depending on the information that we're receiving from the referral source. So depending on the information that's received, we may take an immediate action again, or we may request a medical. We may request a medical from the physician, and it could be from 7 to 21 days. Now, once we receive the medical information, depending on what is said on the medical, then we can take an immediate action, or we can have the individual be seen by a driver safety officer. We will swear them in. We will, in essence, conduct an investigation. It all depends. Since we're dealing with dementia and or Alzheimer's, that's what I'm going to be focusing on. Now, we like the physicians to differentiate between mild, moderate, or severe. It's important for us as the driver safety officer to understand what level we're dealing with. And if the condition is moderate to severe, at that point we follow our policies and procedures, we use our manuals. If it falls under moderate to severe, it will automatically warrant a withdrawal of his or her driving privileges. However, if an individual is referred by the physician and the physician completes a form and says that the condition is mild, we can work with the individual. At that point, we will have them come in person with the medical after the medical has been received. Once they come into the office, they will be required to take a written test. The written test helps us gauge. Not only does it test the individual as far as the rules and the regulations of the road, it's also a form of testing their cognitive thinking. Can they grasp the question with the answer? For example, it's 18 questions. They make 11 errors out of 18 questions, and the doctor is reporting the condition. Then it may be somewhat related. Now, if the individual, we try to give them 3 opportunities. If the individual fails one test and they make again 11 mistakes out of 18, and then they give them another opportunity and they make 12 errors out of 18, then we're going to look at the preponderance of the evidence. If the medical suggests, first of all, we'll go with the referral, and then we'll look at the medical, and then we look at the written test and their performance, their being the actual customer. Depending on how they perform during the reexamination, we'll look at, we'll ask them questions as far as do they have an understanding of their medical conditions. We want to gauge whether or not they have a grasp of their medical condition and what steps he or she needs to do in order to control the condition. That goes with compliance. Are they complying with their medical regimen? So the more information we get from the physician regarding the condition itself, and compliance plays a major role in assisting us, the Driver Safety Division, when we conduct an investigation and what steps we may take. Now, some physicians will not well, let me back up a little. There is a question on page 205 of the driver medical evaluation. That is a form that's issued by the Department of Motor Vehicles, which is completed by the physician. One of the question is, do you advise against driving? Some physicians will leave that blank. It is important for us to have that question answered. You may say, I recommend against driving, but to the right, there's a box where you're recommending a drive test or not recommending a drive test. So if you're advising against driving and you're also advising that a drive test not be given, the likelihood is that it's to a level where it would be unsafe for us to place you on the road with an examiner that will give you the drive test. But if you indicate, I advise against driving, however, I recommend a drive test, so then we need to be fair, because our responsibility as a senior ombudsman or with the driver safety division is we want to treat all our customers with respect, dignity, and with due process. We want to make sure that there is no violation of due process. So if the physician is recommending that a drive test be given, and again advises against driving, then we go back with the initial referral, the driver medical evaluation, their performance during the process, which can involve possibly giving the subject a couple of memory questions, and then we'll ask them to repeat the questions or the questions that we gave them. We will then carry a dialogue with the individual to see how they're performing during the reexamination process. Then we will give them a written examination, which will be one of the steps. Now let's say they pass the written test, or they perform well during the reexamination process, and let's say the doctor does not recommend, or even if the doctor does recommend against driving, but suggests that a drive test be given, then that will be the next level, as long as they pass the written test and they perform well during the reexamination process. Now, during the drive test, they will be given a special drive test. It's more detailed, and it's not your traditional drive test that you take when you first get your California driver's license. One of the, as an example, to give you how detailed it may be, the examiner will be taking them throughout a drive test examination, and maybe as the end result of the drive test, the examiner will tell them, okay, get me back to your local DMV office. The examiner will not give that customer or that driver directions how to get back to the office. We want to see whether or not their cognitive thinking, to what level is it impacting their driving ability. So the examiner will ask them, please get me back to the local DMV office, and they will test that. They will test them to see how well they perform and get back to the office. Now, depending on how they do on the drive test examination, sometimes the errors may be correctable. Maybe it's not in essence related to a certain degree to dementia and or Alzheimer's. They may be due to a lack of skill versus dementia or Alzheimer's. And as the previous presenters indicated, AARP is an excellent resource. AAA is an excellent resource. AAA works in connection with CarFit. CarFit is also an excellent program. They will review the vehicle. They will make measurements of the vehicle. Earlier, someone mentioned, I think, a green Cadillac. Well, maybe 10, 20 years ago, you were able to drive a green Cadillac, but now the program, the CarFit, they will actually take a look at the vehicle, make measurements, make an assessment of the individual, and they'll tell the driver, this vehicle is no longer user-friendly for you. You might need a vehicle that's mid-sized. You might need a vehicle that's smaller. They will make adjustments to the vehicle that may relate to vision disorders or other type of medical conditions. But again, I want to focus on dementia and or Alzheimer's. Now, AARP is excellent because they will identify any areas that need to be corrected when it comes to that person's driving behavior. Now, let's say, as I mentioned earlier, let's say the driver safety officer determines that the errors are more of a lack of skill versus possibly dementia or borderline. then they will recommend AARP or AAA. AAA and AARP is excellent because they work better with senior drivers. Now, if the drive test errors, say for example, they run a red light or they go through a stop sign or they make some mistakes that they were shown in previous slides from previous presenters that relate to dementia, then the driver safety officer will and can take an action, because our responsibility first is highway safety, traffic safety. We need to look out for ourselves. We don't want the driver to get injured. We don't want the driver to injure other individuals on the road. We don't want pedestrians to get injured as a result of allowing someone to drive that may not be in that ability or capacity to be able to drive safely. Okay, all right. Okay, so I'll make it short. It looks like we're out of time. So what happens with the driver safety officer, in essence, they will look at the process. If the driver succeeds at the re-examination level, the medical is favorable, they pass the written test, they pass the drive test, then the Department of Motor Vehicles will place the driver on a restriction where the Department of Motor Vehicles will be monitoring the individual on a regular basis. It could be every 6 months, it could be every 12 months, and possibly every 24 months. So the Department of Motor Vehicles will order what is called a calendar re-examination. We will see the individual periodically. One, we need to obtain a brand new medical to establish whether or not the condition has remained stable and under control or has it worsened. And we will have the subject again go through the same process, re-examination, written test, and possibly a drive test. Now, again, I was told I had 2 minutes, so for now, at this level, any questions that I can answer, and maybe I can elaborate.
Thank you.
Thank you.
Jimmy, I might have missed something, but how do we get hold of your organization?
Okay, I passed up.
Oh, okay.
In front, there's going to be some books called Senior Guide for Safe Driving.
All right.
It's an excellent resource with a lot of information, which includes AARP, AAA. It has on page 50. There are 5 senior driver ombudsmen. One of them's in San Francisco, Sacramento, Los Angeles, which is the senior ombudsman that covers this area, but unfortunately she was unable to make it, so I participated in this one for her. And then there's my region, which is Orange Region, and it's on page 50. My phone number's there. It's my direct line. If I don't answer, it's most likely because I'm out conducting outreach or I'm on the phone with a customer, but my objective is to return the call within 24 hours upon my return. So you can get a hold of me through that book.
Maybe you can just repeat the question right over there.
Yes, if it is a non-physician that reports somebody, what kind of procedure? Is it different for those folks? A neighbor or a relative?
As I mentioned earlier, it depends on that referral. It could be from a social worker, it can be from a neighbor, it can be a relative, a friend. We look at the document depending on how detailed, how much information they provide. That's why one of the previous presenters said, take notes, document, document, document. Well, if you take those notes and you document, when you complete that referral, and that referral can be obtained on the internet, dmv.ca.gov. It can be obtained on that. You complete the form as thorough as possible, and then at that level, we will review the document, and that's where we obtain the medical evidence, and that we determine what's the next level we're going to go, or what's the next level we're going to take. Does that answer the question?
Yeah, I just wondered if it had the same authority as the physicians, because many times, in my
No.
experience, the kids are reticent to do it. They're sort of waiting for the physician.
No, we need a physician because the physician, that's what they went to school for.
Well, sort of.
We're gonna open up the floor so that all of the speakers can address questions. So who had another question? Yes, sir.
If you report someone to the DMV, is that a public document? Will the driver be aware of
Okay.
the report?
There, on that document that I'm indicating where you can refer someone to the Department of Motor Vehicles, you can request to remain confidential. not anonymous, but confidential. We will respect that unless we are ordered by a judge at the judicial level. We will remain, the information will remain confidential. We will not reveal the information unless instructed by a judge at the judicial level.
I have a question.
Dr. Small?
So, you can either give me this mic, or you give me this. We got 5 mics here. So, first of all, I thought it was a tremendous panel. I want to thank all the presenters. It's very informative. One thing that was quite interesting is that Dr. Fitton showed that the collision rate for 85-year-olds is comparable to people in their 20s. But the real high rate is those 16-year-olds. And I was thinking maybe, I have this GPS on my car that shows me the traffic. I'd like to know the concentration of 16-year-olds where they're driving. That might be helpful. But actually, on a more serious note, I'm curious about Dr. Fitton. He mentioned that he's developing a test for MDs to perform. And, in hearing the presentation from you about the DMV, and as a physician where I stand, it's kind of, there's this Netherland. I mean, we don't feel as physicians that we've really learned how to do a precise test of driving. So we're hoping, well, the DMV will do this test, and we're kind of guiding ourselves based on cognitive tests that we're used to. So I'd be very curious to hear about what Dr. Fitton has developed.
Well, I think, Gary, that you've touched upon an important issue, and that's really fine-tuning the interface between physicians who tend to see people with dementia before, particularly primary care physicians, before anybody else does, and the DMV that basically rely on us reporting that a person has cognitive impairment. Now, the issue that I see, there's a couple of problems that I think have been struggled with, and I think some of it has to do with the resources available to you for testing. It's so that you have to find alternative proxies to taking everybody that may need a road test out on the road. However, there is a problem in that, for example, if you rely on physicians to kind of tell you, we think this guy ought to go on the road, off the road, that may not be that valid. Number one, physicians, as you pointed out, are not driving experts. But also, there's this other issue, which is important, that physicians can be dumped by their patients if they do something that the patient doesn't like. And I've been fired by some of my patients because I've had to report them, as the law indicates, to the DMV. So that brings an element of potential bias. Many doctors may not really, they'll say, well, I really don't know, and so they don't have to report the patient that maybe should be reported because there's a conflict of interest for them. They don't want to lose their patient. So I would think that, if the resources were not a limitation, if a patient has a cognitive impairment deemed significant by a physician, that the proof of the pudding is in the testing. They really need to get out and show that they can actually drive or not drive autonomously, not by being given instructions, now turn left, now turn right. The reason we were able to show all of these deficits because we let the patient try to figure things out, which is what happens on the road. I mean, you have to have autonomy. And, but that would require probably that you test more people than you have personnel to do so. So we're caught in a difficult place. As far as helping the physician out, which is what we're trying to do, we have over several studies have been able to refine the actual issues that seem to be most difficult for the road issues that seem to be most difficult for patients, for Alzheimer drivers and other dementia drivers. They tend to revolve around intersections, and particularly when they come upon a novel intersection that they haven't seen before and they have to solve the problem. And they have to do so within a limited amount of time. You can't stand there and stare at the signs in the middle of traffic because that can really cause a problem too. So we have been able to devise a test that has shown very high correlation with the actual road test, where the patients, it takes 2 or 3 minutes to give responses to scenarios, and that can be presented to the patient. And these patients do not do well in the scenarios, just as they don't do well on the road. So we're at the point of coming to an end with the development that we are of that, and it has, I think, some positives in that it's got validity, which some of these tests have very questionable validity as to how that applies on the road. This is developed from the road, so there's high validity on the performance. And the road test that you saw that we gave correlates well with the actual real-life driving record of the patients. Those that have had near misses and accidents and things like that do less well on the road test that we gave them. So we have correlation from the actual driving to the road, from the road to the paper test.
So this is a pencil paper test that the doctor can give in the office?
Yeah, it can be done. It's actually viewing certain scenarios. We have 3 scenarios, look at 3 scenarios, and you make a decision on the scenario. And that decision correlates with what they do on the road. We've demonstrated that. Should take about 3 minutes to go through that, and that will help the doctor when you send them the what do you think? Should this guy ought to be driving or not? And the doctor says, geez, I really don't know. Now the doctor will have something. Look, you failed this validated test. I think we can say that you shouldn't be driving. So in a sense, I hope that that will enhance the collaboration and the validity of the collaboration between doctors and your department.
Excellent points. One, I want to address the question that you were asking earlier about the younger generation. Between the ages of 17 to 20, they are 4 times more likely to be involved in a traffic accident versus someone that's 65. And it goes back to inexperience versus experience. Unfortunately, the younger generation, they feel invincible. As a result, they drive like that, to reflect that. Now, to go back to what you were talking about, the physicians, and you don't have the experience because it comes with driving. I have had physicians, well, they'll leave the box empty, but there's a space on the bottom, and they'll say, at this point, I'm going to leave that determination up to the Department of Motor Vehicles, and they'll just give me a brief synopsis regarding the actual condition, as whether the Alzheimer's and or dementia, what, in their opinion, how they feel that affects their ability, whether it be daily activities, social lives. That's sufficient. You can leave it up to us to make that final determination. You don't have to answer the question. You can leave it blank. But as long as you give us a synopsis in the bottom, I'll leave it up to you. You decide. At this point, you're the one with the experience, which is ultimately are going to be our end to take them on the road. We're not going to allow the driver to continue driving until they can demonstrate or pass all facets of the process successfully before we can give them a license, or at least allowing them to maintain their driving privileges. I'm hoping that answered the question.